Thank you for joining us today for UCA's COVID-19 Town Hall. We have a great team of panelists, and Dr. Sean McNeely will be moderating. Dr. McNeely is a board-certified family physician who has been working in urgent care for over 20 years. He has been president of both UCA and the College of Urgent Care Medicine. He currently remains on both boards of directors and serves as the chair of the COVID task force for UCA and CUCM. Before I turn it over to Sean to make introductions of the panelists, I'm going to just give you a couple of housekeeping announcements. Panelists, you can mute yourself while you're not talking. We're getting some background noise. If anybody's not muted, please do so. And then attendees, if you have any questions throughout the webinar or throughout the town hall, go ahead and type those into the question box. We're going to have a short presentation by all of the panelists, and then we'll come on and take questions. At the end, Dr. McNeely will come back on and ask those questions. You will also receive a copy of this webinar in your email tomorrow. So Dr. McNeely, I'm going to go ahead and turn it over to you.
Great. Good afternoon, everyone. Glad to, I was going to say see you here, but I guess why I only see our panelists. So I appreciate the time everyone's taking today to talk about this. We're going to have a town hall. We're going to do two parts. First, we're going to have each of our panelists present, and then we're going to have question session. While our panelists are presenting, if you guys could just grab us some questions and put them into the box, I'll be following the questions. Anything's fair game. I can't promise you we can answer them all, but these are very difficult times. Things are changing so rapidly, but we'll do our best to help. All right, so let me go ahead and introduce our panelists. On my left is Dr. Joe Toscano. Dr. Toscano has been practicing 30 years in the ED and urgent care space. He currently works in the San Francisco Bay Area. He is also a founding and current board member of the College of Urgent Care Medicine and the clinical content coordinator for UCA. Next on my list there, to my direct left is Dr. Jasmeet Bogle. Dr. Bogle is a family medicine physician trained who has been practicing urgent care for 10 plus years. He served as a president for the College of Urgent Care Medicine since 2017 and still represents the college on the UCA's board. He also serves on the editorial board of the Journal of Urgent Care Medicine. Not pictured on your screen due to some telecommunication difficulties we're having. Dr. Tracy Davidoff is a practicing urgent care physician in Lake Buena Vista, Florida, and currently vice president of the College of Urgent Care Medicine. Dr. Chow, who's also not pictured, is a family practice physician working with Wake Med in Raleigh, North Carolina, and currently serves as the treasurer of the College of Urgent Care Medicine. Finally, in the middle of the three others pictured here is Dr. Burris, who serves as medical director of occupational health for a number of urgent care facilities in New Hampshire. He's principal of a company located in Boston, Massachusetts that serves construction workers, utilities, and other industries. While supporting a number of regional and national companies regarding COVID-19, he has been in the trenches performing contact tracing interviews and making return to work decisions. Dr. Burris is residency trained in both family medicine and occupational medicine and completed his MPH at the Harvard School of Public Health. Welcome, panelists. Glad to have all of you here. Next slide. So COVID-19, just a quick overview. You probably hear this all the time. You see the numbers out there. Worldwide, we're seeing about 6.3 million cases. Unfortunately, been 380,000 deaths that we know of. The United States has seen about 1.8 million cases with just over 100,000 deaths. The economic effect has been staggering. The lifestyle changes have been devastating to all of us, we know, why we're all at home probably rather than in our offices talking to you now. Many of us are wearing masks everywhere we go. And the future remains uncertain. Next slide. Please be aware that there is a Voice of the Industry survey that comes out every few weeks. UCA and the CUCM have created that as part of our COVID task force. This survey is very important. Not only does it help us know what's going on, but it also helps us to share with the industry as well as the media what's happening in urgent care. One of the biggest issues we have with urgent care is we're just quietly in the background. There's as many as 9,000 urgent cares nationally, and no one knows we're there. So some of the questions that were on the survey: have you modified your workflow in your centers as a result of the COVID-19 pandemic? 91% of people responded yes. Next slide. And are your centers currently testing for COVID-19, either the PCR or the IgG or IgM antibodies? We'll have Dr. Chow discuss those a little bit in the future. But here's the some of the information week to week from week 2 to 8 of the survey. The survey, as I said, doesn't come out every week because we don't want to wear you guys out, but it's very important that we get these numbers. As you can see, the testing has gone up over time, although it's kind of remained the same between week 7 and 8. So with no further ado, we're going to go to our first person, Dr. Toscano. Next slide.
Thanks, Sean. Can everybody hear me okay?
Yes, we can.
Perfect. Well, I have to say I'm very proud of folks in urgent care, because when this initially hit, it seemed like there was a lot of uncertainty about how to take care of patients who could have this disease. A lot of people were thinking of just closing their doors and not seeing any patients. And what evolved over those early few weeks is people figuring a lot of things out. I think people who are already taking care of patients, suspected COVID patients, or patients who are known to be positive, have already figured out what I'm going to talk about. I'd like to kind of clue in on a few fine points. And then also, I think this information is going to be important for people who are just beginning to take care of these patients, who are just kind of opening their doors more recently and trying to figure out what's the best way to take care of these folks. Just like with anybody else with an acute complaint, our first job is to determine, could they have the disease? And how do you even do that in a condition where about half the people may be asymptomatic? Cluing into the syndromes that we know exist with respiratory tract infections and GI symptoms, shortness of breath, those are things that we're going to see people present with and begin to suspect that they might have this. Chris is going to actually, one other thing about that initial kind of risk assessment and differential diagnosis process is this finding of anosmia, or loss of sense of smell or taste. It's talked about quite a bit, and it seems to be actually, in somebody with a respiratory syndrome, fairly specific. It doesn't occur a lot of the time, maybe 10, 15, 20% of the time. But when it's present, it seems to actually have a pretty good link to the diagnosis. So it's something for folks to keep in mind. Chris is going to talk about the test, different types of tests, and I have a slide right after this, just about the philosophy of testing. If we apply this test to everybody who walks in the door, we're going to have a lot of false positives and false negatives when we're dealing with populations that don't have high rates of disease. So we have to be a little bit careful about that. I think right now we're screening a lot of people, which is probably helpful. We're being told that that's helpful, but we need to understand the implications of positive and negative results in those situations. So I'll talk a little bit about that. Our main job in somebody, if you have the rapid test, you can make that determination. Yes, they have COVID. No, they don't. I don't know that a lot of people have that rapid result. So we're sending out a test and getting the results back later. You want to assess the patient for their level of illness, and folks who are really sick, those folks are going to be referred on to a higher level of care. This idea of silent hypoxia or happy hypoxemics, patients who seem like they're well, maybe have a little bit of shortness of breath, and you slap a pulse ox on them and it's incredibly low. That's kind of one of the hallmarks of the disease and something we need to screen for. So pulse oxes are important, as well as our gestalt of the patient, their level of distress in terms of assessing their level of illness. One of our most important roles, whether we know a patient has COVID or not, if they're suspected or if they've been exposed, is to counsel them on the appropriate level of self-isolation. There's the shelter-in-place orders that are public health orders across the country, but in addition, within their own homes, people who have been exposed need to quarantine. People who have symptoms and are awaiting test results need to self-isolate. the CDC has guidance about this, and actually county health departments sometimes have stricter guidelines. So it's important to know those. The last point I want to make is actually to avoid COVID tunnel vision. And what I mean by that is, I think patient comes in, they're sick, you do the test, you send it out, you're waiting the negative result, you counsel them. And I think a lot of times you breathe a sigh of relief as the patient leaves the door, but we still need to consider that some of these patients could have pneumonia, pyelonephritis, other conditions. Actually, working in the ED, we've seen a couple patients with viral meningitis who were awaiting COVID test results. And it was a couple of days later, so it may not have been obvious that they had viral meningitis at that first contact, but people still have these other conditions and can appear sick. So it's not just a matter of do they have COVID or not, but we still have our role in terms of making sure patients with acute symptoms aren't sick with other diseases. Next slide, please. So this is just a kind of a slide to highlight our use of tests. Again, Chris is going to talk about some specific tests that are available to us. But what all this actually indicates is the positive predictive value and negative predictive value of a test applied to different populations. So we don't have a test that's 95% sensitive or 95% specific that we know of. And actually, if you take a test that is both 95% sensitive and 95% specific and apply it in these couple situations, this is what you get. On the left, if you're just screening tons of people who may or may not have the infection and the prevalence among them is low, let's say 3%, your 95% test is actually going to have a positive predictive value of only 37%, because you're going to have a lot of false positives, that number of 48 there. It's still going to be very specific, so a positive result's going to be believable, but testing a bunch of people who may not have the disease, even with a very sensitive test, is going to lead to a low positive predictive value. As prevalence rises, so if you're testing a population where 20% of the people have the disease, your positive predictive value goes up quite a bit. Again, 95% sensitive, 95% specific, but with that higher prevalence, the test is going to be more closely linked to the diagnosis. So whatever test you're using, knowing the test specifics is important, but also knowing what population you're testing. Are you just screening everybody who walks in, or are you making a kind of a determination of what the pretest probability is? Yeah, this patient's 25% likely to have the infection, then that positive test result is going to mean a lot more. All right, next, please. And then, I think a lot of people are contemplating, a lot of us are putting our heads down and just taking care of this now because it is very demanding. But what is the future role that we have with COVID and apart from COVID, given what's happened? A lot of us are doing things much differently. Telemedicine, which is very helpful in general, certainly really helpful with COVID, is rising in importance. What we need to do is not let our guard down. We need to continue to wear PPE when we're taking care of patients and the diseases in the community. And we need to do what we're doing. We figured it out. I think a lot of times the first couple dozen suspected COVID patients, you really didn't have a workflow for it. But as long as we can continue to do that efficiently and effectively and refine how we do it, urgent care is going to have a role in the care of these patients in the future. Beyond just evaluating patients for COVID and testing them, urgent care actually is already fulfilling a role, a public health role, and I think that can probably be expanded, particularly if we see more disease in the future. More and more tests are being done in the urgent care space. I don't know a lot of people are involved in contact tracing, but it's going to be an important element of the return to normal. Urgent care could have a role in that. Public health departments are kind of overwhelmed with doing that. And then once a vaccine becomes available, the urgent care space is a great place for people to get vaccinated once we have an effective, safe vaccine. I think we all need to keep in mind that there could be a second wave of illness. It was felt to be inevitable initially, and now maybe a little bit less likely. But being aware if we start to see more patients come in with suspicious symptoms and a higher rate of positive tests or sick patients with this disease, the urgent care clinician could be the one that defines that second wave at the beginning of it. And then finally, this was a little more important in Italy particularly, and they were doing this out of EDs, where patients who were sent home weren't just sent home with precautions to come back if they felt worse. There were actually regular check-ins with those patients. They have a socialized medicine, which is not exactly the same, but urgent care could emerge as the venue to be able to manage these patients, daily check-in phone calls. And actually in Italy, they were sending patients home with pulse oximeters to screen for this silent hypoxia, which, number one, is an important indicator apart from how the patient feels that they need to return and be reevaluated, but also gives you and the patient a sense of how the disease is progressing. So those are some things that are interesting to contemplate in terms of urgent care in the future with COVID-19.
Great. Thank you very much, Dr. Toscano. We're going to hold our questions to the end so we can get through the presentations, and then we'll let the panel answer all our questions as we go through it. Next on the list is Dr. Bogler. He's going to talk to us about kids.
Sure. Thank you, Dr. McNeely. Thank you, everyone, for being on this panel, and also to the audience for being on this webinar. As if we were not having a lot of uncertainty with adults, we now have even more uncertainty with children when it comes to COVID-19. Maybe we were not seeing a whole lot of kids initially, maybe just because of our criteria for testing being stricter, and now they're loosening up a little bit. Who knows what the reason was, but that does lead to a lack of data in terms of good evidence-based care. So I just wanted to start with the basic question of, are kids getting infected with COVID-19 or the SARS-CoV-2 virus, if you would like to call that? And the simple answer is yes. In the United States, we have seen that less than 2% of the patients who have been infected with COVID-19 were under the age of 18. Small number, but still something that we need to be on a lookout for, which brings us to the next obvious question. Should we really be worried about COVID-19 in children? And the answer is a resounding yes and a maybe. The reason is, from the data that we have, the minimal data that we really have from the US, from China, and from Italy, what we're seeing is that the concern is that kids less than 1 year of age are the ones who are accounting for the most hospital admissions in terms of COVID-19 in children. They're also ending up with more serious and critical disease. The good news is that most of the pediatric age group is getting mild to moderate symptoms. So it's self-limiting, which is a great thing. But the problem is that the ones who do progress and deteriorate to a more serious form of this illness, the rate of complications is much, much higher in them. As of April, if you go to the CDC's website, there have only been 3 reported deaths in the pediatric age group. These patients were tested positive for COVID, for the SARS-CoV-2 virus. An exact connection or relation between the presence of the virus and the death is still not confirmed, but it does raise a little bit of a concern in the pediatric age group. The next question being, that comes to mind is, how does COVID illness in children compare to that in adults? And I think that's where it becomes very tough clinically to differentiate, between adults and children, whether they have COVID or not. In adults, what we have seen over the last few months is obviously low respiratory symptoms, cough, shortness of breath. Those kind of have predominated our thought process when we are seeing, adults clinically. There's some evidence, not a whole lot, but some evidence to suggest that in kids, this virus might be attacking more of the upper respiratory tract, which could be the reason that symptoms end up being mild to moderate. They don't usually progress to a severe illness. So that's kind of reassuring, but very tough clinically to make a diagnosis upon. Some studies are also seeing that it's more of the GI symptoms that are more common in kids as compared to adults. So they might end up coming with diarrhea, or vomiting, these kind or abdominal pain. When we talk about seriousness of this illness in kids, the one diagnosis that has been, kind of in the spotlight and has been a lot in the highlighted a lot is MISC, and I just want to talk a little bit about what this is, so that hopefully we can get an understanding of what do we need to look for in children. So basically, it's a novel pediatric vasculitis that we have seen in some studies coming out of Italy and even in the US in areas where we have seen COVID-19 in the pediatric age group. The clinical presentation in this is more in line with what you would see with Kawasaki's disease and maybe with toxic shock syndrome. The difference, there are subtle differentiating factors. Again, I would not pin my entire diagnosis on that, but we're seeing this form of Kawasaki's with COVID-19 in kids who are usually older in age group. So the average age being around 7.5 years. But again, it does not mean that we can easily exclude that diagnosis in a younger kid who's coming with Kawasaki's like features. The concern obviously is, and by the way, the presentation is more, as something of a persistent fever. They can develop a rash. You can see changes on the mucous linings, on the lips, on the tongue. Sometimes they can have swollen feet and or swollen hands. So the presentation ends up being more like a Kawasaki's disease, not maybe incomplete, but something to consider as we all see patients in our real practices. And basically, it's this whole syndrome of issues that has been given the name, multi-system inflammatory syndrome in children, aka MISC. So please be careful in your clinical practices when you're seeing patients, when you're seeing kids, because it's important to recognize this illness. And if they do present with features that could be suggestive of it, we would highly recommend calling your local, peds emergency room or the pediatrician, going through the case with them, because these cases might deteriorate quickly. They might look fine initially, but there's a chance they might deteriorate quickly, and they might actually need, inotropic support. They might need fluids and whatnot in the ED. So we really need to be careful and have a follow-up with them. And lastly, how do you protect children when they come to urgent care to be seen for other illnesses, right? They have not stopped falling. Kids have not stopped falling. Kids, have not stopped having other issues. They still cut themselves. They still bump their heads into things. And we are still seeing them in an urgent care setup. So, it kind of goes down to the basics. If a kid is presenting with non-COVID-19 issues, then the whole idea is to minimize their exposure to possible COVID-19 while they are in your clinic. And some simple ways to do that is having them wait outside in the car with their parents, until their time is, it's time for them to go into the exam room, minimizing exposure in the waiting areas. Again, take them back directly, have them wear a mask. Mask is such an important part of this. The kids should be wearing a mask just like adults, and like I said, bringing them back directly into the exam room. And then finally, if a kid is there for a COVID-19 evaluation, or if you tested them and they are positive, then like I said, it's still the same recommendations. Have them wear a mask, minimize their time in the waiting room and whatnot. But at the same time, number one, get a good history and do a good physical so that you don't miss out on that rash or on those subtle mucosal findings. And number two, like I said, please call your local pediatrician or the local peds ER to make sure that you discuss the case and make sure that the patient can go home safely, number one, hopefully. If not, they go to the emergency room to get the right care, and then also help arrange for follow-up for these kids, because like I said, the progression of the disease in kids is something that I think we all need to be concerned about. And that's it from my side, John. Thank you.
Thank you very much, Dr. Bogle. Dr. Struzzulo from our COVID task force also mentioned that there was a May 19th call from the CDC that had a great bit of information on this. So we're going to go into diagnostic testing now. We will have Dr. Chow present to us. Dr. Chow, you've got quite a bit of slides, but we need to have some time for people to also ask some questions. So I'd ask you to kind of make sure you go through them quickly. Thanks. Chris, are you out there?
Sean, can you hear me?
I can now. You're echoing a little bit.
Okay,
We can hear
great.
you.
Let me turn off this. Thanks, everyone. I'm sorry due to technical difficulties, no one could really see my long hair that has been propagating since haircuts are verboten in North Carolina. Some basic background, and this is more for patient questions. SARS-CoV-2 is the virus, COVID-19 is the disease. All testing right now is performed under EUA, Emergency Use Authorization, and this is a rapidly evolving situation with new EUAs granted weekly or even daily. A quick timeline of EUA approvals. 2/4/2020, the CDC coronavirus test got an EUA, followed by the Cepheid, Express, Abbott, Celix, Sophia. Celix is the first IgM rapid test, and Sophia is a protein antigen test. So you can see the timeline. A quick comment on radiological testing. JUSUM had a wonderful article in the May 2020 issue that addressed what is the role of chest x-rays for the diagnosis of COVID-19. 58.3% of patients with COVID-19 had a normal chest x-ray, and 89% had only normal or mildly abnormal findings. So chest x-ray is not reliable for a diagnosis of COVID.
Chris, we can't hear you.
Dr. Chow, are you out there? Okay, why don't we go ahead to the next slide and we'll kind of advance through, and if he gets back on, we'll go back to him. Go ahead for a few slides forward there, Carl. Let's get to the treatment slides. Okay, so medications in SARS-CoV-2. Dr. Davidoff?
That would be me. Thank you very much. So this was a pretty easy thing to talk about. What I really wanted to do for my slides was just put up one slide with one of those great big red circles with the slash through it, and no. Because honestly, for outpatient management of SARS-CoV-2, COVID-19, there really are no approved outpatient treatments. Obviously, in an urgent care setting, we're not going to be concerning ourselves with what inpatient treatments are. And rightfully so, all the research talk and push to treat is now currently really only with the inpatients, because those are the ones that are at risk of dying. So not too many people are looking at how to treat an outpatient at this point, or the patients that we're more likely to see. There are no currently recommended treatments for the pre or post-exposure prophylaxis against this virus. So taking your hydroxychloroquine or having a Z-Pack or whatever to try and prevent yourself from getting sick is not something that's been proven to work in any platform and is not recommended. There are no current recommendations of treatments for non-hospitalized patients at this point. So person you diagnose as having COVID-19 either by just clinical grounds or by actually having a positive test, there is no specific treatment to cure their illness at this point. All current treatment recommendations are only for seriously ill and hospitalized patients only. So out of an urgent care, from an urgent care standpoint, even a primary care standpoint, we should not be prescribing hydroxychloroquine either with or without azithromycin for these patients for a couple reasons. One, it hasn't been proven to work. Two, it might be detrimental. And three, there are a fair number of people with chronic rheumatologic diseases walking around out there that need their hydroxychloroquine to function. And by taking all of this away and stockpiling it for our potential use against COVID would be detrimental to their health as well. So just say no. Very few patients have asked me for any medications. I do know a fair amount of providers that are writing Z-Packs for anybody they think has COVID. This is not recommended. There are no trials that prove that it's worked, and you could be doing potential harm either by allergic reaction, side effects, antibiotic stewardship, which is a whole nother can of worms, which I'll get to in a minute. So education is the key. Explain to them that there's been nothing proven that's worked. There's a lot of anecdotal evidence out there, but nothing has panned out to be useful for these patients. Steroids, there's been a lot of talk about steroids. Should you put prednisone on people? In the South, we love prednisone down here. Anybody has any sort of an upper respiratory type illness, they get some steroids. Actually not recommended in this case, and there have been a few articles that have been published, specifically recent guidelines that have come out from the National Institute of Health earlier in May, which said steroids are absolutely not recommended except in very, very specific indications. One would be sepsis, which is something we shouldn't be treating in urgent care, obviously, and the other one would be either COPD or asthma, where they're having a significant reactive airway type scenario that would require steroids. But routine use of corticosteroids for the COVID patient is not recommended at this point. Next slide, please. In the very beginning of this, there was a whole big talk about people on ACE inhibitors and angiotensin receptor blockers. The virus itself, the coronavirus, does get into human cells using the ACE receptor. So there was a thought, either one, that if you're on an ACE inhibitor, you have now upregulated your receptors, and that's making you more receptive to developing the COVID infection. And then there was another thought that the inhibitors might actually block the reception, and that maybe it would be a good idea to put people on the ACE inhibitors. But over the last few months, as we've studied this and looked into it, it's been determined that neither of those two things really pan out, that you should not be stopping ACE inhibitors or ARBs on patients that are already chronically on them, because they need them for their blood pressure, and it would be more detrimental to them to stop it than it would be to just continue it. And then the other end of that is, don't start somebody on an ACE inhibitor thinking you're going to be doing anything for them with their COVID-19 illness, because it's not been proven to do anything. Again, also at the beginning of the pandemic in the US, there was thoughts about ibuprofen, non-steroidal anti-inflammatories, being a bad thing, that it may somehow increase the cytokine storm and cause some problems there. That is also not panned out, and NSAIDs are, how do I say this, not to be not recommended. Like, you can use them, but they're suggesting that perhaps you should be trying Tylenol first for fever management. But if that doesn't work, or if you need something stronger for aches and pains, that it is okay to use standard dose NSAIDs such as ibuprofen for fever and pain. Don't forget, this is an upper respiratory tract illness. These people are coughing. They want some cough medicine. That's fine. There's no reason why you can't treat it as any other respiratory infection. And recommend whatever cough medicine, cough drops, if you like to go all natural and do tea and honey and that sort of thing. Telling them what they can do is very helpful than just telling them that there's nothing you can do for them. So make some other recommendations for other things for symptom relief. Just a quick word about supplements. There's a lot of talk on the internet going around about different supplements one can use to improve their situation if they get diagnosed with this, or to prevent this. Vitamin D is being looked at. There's actually some studies now with vitamin C, using high-dose IV vitamin C for hospitalized patients, thinking it might work on that cytokine storm I was talking about. Zinc has been long thought to prevent binding of the virus in the respiratory tract. And elderberry is a recent hot topic now, even for pediatrics, for the common cold. Again, this virus has only been around 6-7 months. There's not enough studies. There are no studies to show whether any of this is effective or not. Most of this stuff is pretty harmless taken in regular doses, but you do need to realize that there are a lot of people out there that think, oh, vitamin D is good, or let me take 12, and they're going to take super doses of these things thinking that they're going to prevent themselves. And there are problems with those things. Excessive vitamin D can result in hypercalcemia. You can end up with some kidney stones. Vitamin C can also lead to kidney stones. Zinc can displace other minerals and cause other mineral deficiencies. And if people are actually eating actual elderberries, I just looked this up this morning, you can get cyanide poisoning from elderberries if you're eating raw elderberries. The the commercial preparations have taken that out because it's in the seeds that cause it. So there's none in the commercial products. But too much of anything is not always a good thing. So just make sure that if patients ask you about this, you caution them to take the recommended doses and not to exceed things. Now, I did not mention antibiotic stewardship here. This was the hot topic in urgent care for the last couple of years before we got hit with this pandemic. Now we're all into this, and we're sort of, I don't want to say forgetting about antibiotic stewardship, but it's not on the forefront of our minds at this point. We're in a situation where not all patients can be seen in person. So we're doing it telemedicine. People are calling their primary care doctors on the phone. They're seeing, them face-to-face on a computer, but not in person. There's been a surge of excessive antibiotic writing. Upper respiratory tract viral infections are still upper respiratory viral tract infections, even if you can't put your hands on the patient. We should not be ordering Z-Paks willy-nilly just because we can't physically see the patient, just in case. Should not be treating with sore throats with amoxicillin unless there's clear evidence that it's probably strep. So just, keep that in mind. Antibiotic stewardship is still something that we should be thinking about. We should not be over prescribing. We don't want to end up with super bugs as a result of this super virus that we've been dealing with now. Think about the future and a few years up the road, where we might be if we create some more super bugs by over prescribing antibiotics that are unnecessary at this point. So just a thought. Thank you.
All right. Thank you, Dr. Davidoff. Great points on medications, what we should and shouldn't be doing. And, the struggle in urgent care, once again, it's like the common cold in a lot of ways. We don't have a lot of tools to work with, but we help our patients get through it, and we know when they need to go see someone else. So we're going to go ahead and go to the occupational medicine and return to work part, and then we'll bump back to Dr. Chow if we're able to get him in time-wise, and he's still with us. So, Dr. Burris? Are you on mute? I can't hear you.
Oh, yes. Now? Thank you, Dr. Miller. You can hear me now, correct? I do hope that Chris Chow can rejoin us because the testing is so important with regards to return to work. So I'm going to try to cover 4 different points or scenarios. One has to do with the symptomatic individual with COVID-19 and a person either having a positive test or presumed positive, and which strategy might be used, either a symptom or time-based or a test-based strategy, and relative merits of both. I want to spend some time about the asymptomatic or pre-symptomatic individuals because that's quite difficult. I'd like to have us focus on the person under investigation a bit in terms of how to handle that. And lastly, how to think about the individuals at high risk of mortality if and when they do get infected. Next slide, please. Thank you. So return to work strategies when the individual has a positive COVID test with symptoms. Okay, so for me, the easiest is I call the individual perhaps is a utility worker in a town, somewhere in the US, and I find out when that person's onset of symptoms were, and then I can tell them, unless you have a persistent case where there's multiple spikes of fever over longer periods of time than we thought, you should be able to return to work after at least 10 days with a couple of stipulations. For example, that you've had no fever for 3 days off of fever-reducing meds and your symptoms are better, not completely gone. The CDC recommends that person would continue using a mask if they do go back to work at that point for at least through the day 14. Most of the workplaces I'm helping with now, everybody's wearing a mask anyway. And one caveat, and this goes to the question of what can urgent care providers perhaps evolve into, if you do help with the contact tracing or decisions about when to return to work, there often is a value in a second interview towards the end of the course, because some people have persisting symptoms, and I've seen that. For some people, it used to be 7 days. On May 3rd, it changed to 10 days. But even with 7 days, and I returned probably hundreds of people back to work after 7 days, I didn't have any secondary cases. There was a nice study out of Germany that showed most of the viral shedding is early in the course. So that's symptom-based versus test-based. Test-based would be, oh, okay, so the company says, I'm not going to let you back to work until you've had 2 negative tests separated by 24 hours. Now, that was a high bar early on when there wasn't ample testing. I couldn't get any of my mild COVID positive patients tested at first, none. I couldn't get them tested. The urgent cares weren't testing at that point. Now it's quite easy, but back then you couldn't. And I have had instances, mostly where a plant is shut down because of a very high prevalence of COVID, and then the whole plant shuts down, things are addressed, and then as part of the return or the restart of the plant, everybody gets tested. I've sent over 200 people to one urgent care to get tested at $150 a pop, by the way. The problem with the test-based is that some have persistent positives, and it's not associated with a positive culture, and they're not thought to be infectious. So it is problematic, and I prefer a symptom-based. Next slide, please. If we could talk about the asymptomatic, or for all we know, they might be pre-symptomatic. And I saw an interesting statistic. This statistic said that 44% of the spread comes from the pre-symptomatic phase. When you do a contact tracing right now, the public health, they say look back 48 hours. But there's some information that they might be symptomatic even before, which is concerning. So for the asymptomatic person, which I'm seeing a lot of, there'll be a group, they all commute together, even though they're not supposed to, and one will be positive, so the company will send everybody in the vehicle to be tested, and there'll be 2 out of 4 that will be COVID positive but no symptoms. So what do you do with that individual? What the CDC recommends is whatever the day of that first positive COVID test, you say, okay, you're out of work for 10 days, and then providing that you can be 3 days without fever, off fever-reducing meds, you can return to work after that. So that's time-based. Test-based would be similar to what we talked about before, exclude the person from work until they have 2 consecutive specimens collected at least 24 hours apart. Again, the caveat is some will have persistent positive PCRs. Next slide. So what to do with the person under investigation? I get a lot of calls on this, and one important trick or point is, please don't forget to tell if their household, they're in the same household, to separate as soon as possible so that the second person, their incubation period can start and the 14 days can go by. If they have continued contact, you don't know when to start their incubation period. And so for that individual to return to work, you're going to end up adding a lot of days if they haven't separated. But I don't know if people have noticed this, but for a person that's known to be infected and having had symptoms, they could potentially leave the isolation and return to work before a person that has actually been potentially exposed. And I've had that happen multiple times. It's the 14-day quarantine period that we all know of. And one caveat is if you're an emergency room doctor or someone, for example, in a power plant where there's only 3 of you, there is a possibility to work with a mask on with some other stipulations, but it's quite risky, especially given that pre-symptomatic viral shed period that I mentioned. Most of the utility companies that I've worked with have been reluctant to do that. They wanted to take those extra precautions and honor that 14-day incubation period. And if someone's in their incubation period and develops symptoms, then you switch over to the symptoms-based strategy of return to work. Next slide, please. Has Chris returned? No?
Yes, can you hear me?
Oh, good. Yes, Chris. I'll just do this
Great.
talk, and then perhaps you can talk more about the testing, okay? Great.
Great.
Yes. So for individuals at high risk of mortality, if infected, I would just say that what's being done is that person is encouraged to self-identify. And then the companies are encouraged to protect those employees who are at higher risk, supporting them, encouraging telehealth, or accommodating them as best feasible. Now, I have had one worker who was terminated after having self-identified, and I can tell you he was already circling with regards to attorneys. I don't think that's going to go well for the company. The EEOC has on their website, they have a list of questions, and one of them has to do with may an employer postpone start date or withdraw an offer if the person is over 65 or pregnant? And the answer is no. So I would leave it at that, and hopefully Chris can rejoin us. And I would just add that there are some additional references on the next slide that are quite helpful. Go ahead.
Okay, thanks. Can everyone hear me?
Yes, we can.
Great. Thank you, John. So, Sean, can you back up yet one more slide? So basically, the testing for, I don't know where I cut off. So basically, CT scan is great, but again, that's a very expensive way of diagnosing COVID. Next slide. With regards to testing, basically there are 2 ways of testing. You test for the presence of a virus, i.e. an acute infection or asymptomatic infection, or you're testing for antibodies. Among the testing for SARS-CoV-2, there's nucleic acid detection, or NAT, that can either be done under a reverse transcriptase PCR or isothermal NAT, or you can do antigen detection, where you're detecting SARS-CoV surface proteins. With regards to antibody testing, you're looking for primarily IgG, but there are tests available for IgM and IgA. Next slide, please. The RT-PCR has the highest sensitivities of all the tests, reported to be 90% or higher. The main disadvantage is the runtime length, because you have to go through thermal cycles of the PCR. The isothermal NAT, which is the Abbott test, can deliver results in 5 to 15 minutes, but there has been recent concerns raised about sensitivity, and that is being investigated. The viral protein antigen protein detection can deliver rapid results, but the sensitivity is lower than nucleic acid detection. We're looking at 80 to 82%, which is what's reported in the SOPHIA system. The other challenge with protein antigen is finding a protein antigen that is specific to the SARS-CoV-2 virus. Next slide, please. Antibody testing it's really been in the news a lot, and I see it on Facebook, social media, where people are promoting it as, hey, find out if that cold that you had back in January, or find out if that pneumonia that you had in January was due to SARS-CoV-2 or COVID. There's a problem with that. The antibody test should not be used as a sole basis to diagnose or exclude SARS-CoV-2 infection or COVID, or even to inform infection status. The reason is that the antibodies may take several days to weeks to develop, so a negative test does not rule out active disease. A positive result may be due to past infection or present infection with a non-SARS-CoV-2 coronavirus. There are other strains of coronaviruses out there. And a positive result does not indicate that the patient is immune or cannot be reinfected. The bottom line is we don't know the timeline of how the body produces antibodies to SARS-CoV-2. It's assumed that it's similar to any other infection, but we don't have the data to support that. If you do choose to provide antibody testing, it is critical that you review the results with the patient to ensure that they understand the proper interpretation of the test result. It's not, oh, your antibody test is positive, you're good to go, you'll never get COVID. That is the wrong message and a very dangerous message that is being sent out there. Next slide, please. In terms of collection, the primary collection is nasopharyngeal, which is collected by a healthcare provider. Oral pharyngeal specimens may also be collected. There's also nasal mid-turbinate swabs, anterior nasal swabs, and nasopharyngeal wash. Next. And this is a graphic simply on WikiCommons that shows the nasopharyngeal swab and a throat swab for COVID-19 testing. Next. What else is out there? There is saliva testing that is approved, and there's also home collection that is now approved under EUA. And these are self-collection kits of nasal swab and saline, and you mail it to the laboratory. And on May 8th, a EUA was approved for home collection of a saliva sample. There is a company in Israel called Centec Medical that has started a trial for COVID-19 breath test. So this is what's in the future that may be available for your urgent care center. Next slide. I think that's it, Sean.
Excellent. Thank you very much. We appreciate it, Dr. Chow. So before we go to the general questions, I'm going to just ask the panelists one at a time to go through. And if you could just say if there was one thing from your part of this presentation that you wanted someone to remember, what would it be? And of course, Dr. Toscano, you're going first, so you're going to have to be off the cuff and hurry. So what do you think? Are you on mute?
Okay, I just had to unmute. I think the tests seem to be what interests people the most. And I think understanding the test characteristics and your process of testing, whom you're testing, what their pretest probability is, so that, the math regarding that is the math. You can't change that, but being able to make a diagnosis based on that orderly process, I think, is something we need to focus on. And I think we'll learn more about these tests and how they perform over time. So be on the lookout for that data.
Excellent. Greatly appreciate that. How about Dr. Bogle? What would be your big take home? And it doesn't have to be with your part, but what would you say is the biggest take home?
I think we need to continue having our respect for this virus when it comes to pediatric population as well. The data is very limited, and we need to recognize that. But at the same time, we need to be careful of the serious, symptoms and signs of illness, of the MISC that the patients and the kids can present with, because after all, we are concerned about the same kinds of complications, cardiac complications, as we would be in a case of Kawasaki's. And there's some evidence from Italy to show that these complications might be a little more serious when it comes to patients who have those symptoms, who have signs and symptoms of Kawasaki's, but at the same time also have had confirmed laboratory tests positive for the SARS-CoV-2 virus. So I think we need to continue respecting this virus in that age group as well.
Thank you very much. Dr. Davidoff?
I think I would like my take home to be, we should always be practicing evidence-based medicine, and just because we're stuck in the middle of a frantic pandemic, that our practices should not go out the window. There are no randomized controlled trials that prove there's anything useful for outpatient treatment, so we shouldn't be grasping at straws and writing prescriptions for things that are potentially harmful and haven't been proven to work. The other take home to that I say for every lecture I give is, patient education is totally key. If you explain to people why you're doing what you're doing and how you're doing it, that, that understanding goes a long way, and is often equivalent to writing a prescription for something to make them think that you've done something for them. So that would be my take home.
Great. Dr. Chow?
Sean? Okay,
Yes.
Thank you. My take, I know I talked a lot about testing, but my take home actually is to reemphasize what Dr. Toscano said about avoiding COVID tunnel vision. In the South and in the Midwest, be aware that this is tick season, and tick-borne illnesses like Rocky Mountain spotted fever can present with a fever, chills, upper respiratory infection, or pneumonia. So just because we're in the middle of COVID and someone comes in with fever, chills, cough, myalgias, you got to always think about alternative diagnoses. In the example of a tick-borne spotted fever, you could actually kill someone by missing that diagnosis.
Great. Thank you very much. Very important. I agree with that one as well. Not that I didn't agree with all the others. Okay. And then Dr. Burrows.
Yes, my take home would be to emphasize the importance of the urgent care provider in cycling people out of and then safely and efficiently back into the workplace and avoid the peak of their viral shed. And in so doing, help to reduce stigma, reassure people that it's safe to do so. I myself have two coworkers, members of my team in my company, that have had COVID, one of whom's father was in the ICU on a ventilator for 3 weeks. I'm living in Boston. Some sections of it is as high, if not higher, in terms of prevalence than New York City. So it's very important, I think, for us to do our jobs as providers and reassure people that life is going to go on after having had this particular illness.
Got to get myself off mute. Apologize for that. Great. Thank you very much. So we had some questions for the panel that we've had some before and some after. So the first question is, what is the appropriate time frame for testing? So when you're looking at testing for the person who may be acutely ill, and then secondly, when you're looking for the person who you want to know were they positive for the antibody. It sounds like the answer to testing for antibody is we still don't know what that means. I know that my hospital organization is just now starting to test for the antibodies, but it's within a study. It's not something we're going to use to make any decisions. Others on the panel have thoughts on this?
Sean, I think you hit it right on the nose. The antibody testing right now is primarily for studies and for epidemiology. From a clinical standpoint, the antibody test doesn't really help you as a clinician. In terms of the viral testing, either the nucleic acid test or the antigen test, I think that could be tested anytime you suspect that someone may have active disease.
Okay.
I have some input on that too. I actually can share with you that I also had the COVID infection myself, and I am participating in a trial of donating plasma for use in critically ill patients, of giving them plasma. After speaking with the company that's doing the harvesting of the plasma, they test you for the antibody first, obviously, before they suck up your plasma, but they will not test anybody until it's been 14 days post onset of your first positive test. So they're using a 14-day, 2-week window as when they think the IgG would first become positive.
Any input, and was that something that they're seeing is correct, or that's long enough?
I would imagine. I don't think they would want to, have to test people multiple times. So I would assume most people who are going to generate IgG are going to do it by 2 weeks.
Sean, I have 2 comments about the antibody testing, if I may. Yes.
Go ahead.
So first off, as an occupational medicine specialist, if you will, a lot of my companies are very eager for the potential role of an antibody test. There's huge demand, and there are people that are selling this product perhaps prematurely. One of the worst case scenarios I foresee, I can see, is company X tests all their employees. They tell the worker, oh, you're antibody positive. That worker is now lax, cavalier with their PPE, and gets infected. Takes that infection home. His infection goes under workers' compensation, but what about his 95-year-old grandmother or his 3-year-old, 7-year-old child who has a severe illness? Is that a potential third-party, liability for the company then? So I would very much encourage the urgent cares to hold off. I myself have had an antibody test. There are 2 pages of caveats that come with that test. Do not use this test for X, Y, and Z. Everybody's chomping at the bit to use that, but we don't have a benchmark, forward-facing, okay, this is how we used it, 1,000 employees, and these were all the repercussions. We don't have anything like that to benchmark. So the occupational medicine, I think, area sees its potential, but we're holding back as of yet.
Great. Thank you very much. Great, important thoughts. If we don't know what the test does, it's a bad idea to keep getting it until we've sure, and that's why we have studies out there. So that's very appropriate. We do have still quite a bit of questions out there. One of the ones that we were asked beforehand, I think, is pretty important. It is now 3 o'clock, actually 3:01 on the East Coast and 2 o'clock Central was when we were supposed to end, but the team has agreed to stay on a little longer and answer some more questions. So if you want to stay on, you're welcome to stay on. This is being recorded, so it will be available to all who were participating later on. So a great question is, how are we preparing for the fall with the mix of flu and COVID? How are we going to deal with that when the fever starts again, maybe even just with strep? Why don't we go through the whole panel? Dr. Toscano?
Yeah, I think, the earliest part of the pandemic, people were having to deal with that. With the overlap in symptomatology, that kind of making a decision about pretest probability is a little bit more challenging because oftentimes COVID is an influenza-like illness in terms of its presentation. Luckily, we have pretty decent tests for influenza, which can help us make or rule out that diagnosis. The issue that I see that's going to be challenging is co-infection. Right now, when there's no flu, we're not really worried about co-infection, but there were several studies that came out, the initial part of COVID was toward the end of flu season, that co-infection occurred. It occurred at different rates and probably mostly related to how much flu there was circulating. So we're gonna have to be careful. I'm gonna have to wear PPE because, we should probably be wearing PPE for all of our flu patients. I think for years, you go in the room with somebody with cough and fever, and I don't really never wore a mask. I wash my hands a lot, but so we're gonna have to meet that challenge by protecting ourselves and our staff, by deciding on the pretest probability of those 2 things, and there's going to be overlap, and then applying testing. Again, we know a lot about the flu tests, and hopefully by then we'll know more about the test characteristics of the molecular COVID-19 tests so that we can make the right decisions diagnostically.
Dr. Bogle?
Yeah, I think it's going to be a huge opportunity for us to promote vaccination around, flu, the good old flu shots. I think that's going to be a key component, and I hope that our patients and the general public, appreciate the importance of vaccination even more, because every other household is doing a research right now to, bring out a new vaccine for COVID-19. So, I think that will be an important part of it. My concern is that we have really not had enough, information /studies /data around COVID-19. And we don't know, to Joe's point, we don't know how, the presence of both flu and COVID-19 in someone's body is going to, impact them. I think that's going to be a huge challenge. We'll need to be extra careful about monitoring vital signs and, again, taking a good history and doing a good physical in the urgent care, because chances are more often than not as compared to previously, we might need to send more patients to the emergency room if they're really unstable and, and we have genuine concerns about them. So I think we'll need to be extra careful in the urgent care setup, but it's both opportunity and, a concern that I see in the future.
Thank you. Dr. Davidoff?
Well, I'm actually hopeful for influenza season, which sounds like a strange thing to say, but with all the social distancing that we're doing and the mask wearing that we're doing and the hand washing and all those things that the general population has gotten used to doing more of, I'm really hoping that we're going to see less of a flu season this year. It amazes me how all the upper respiratory tract infections just magically disappear. All the kids went home from school and haven't been interacting with each other. So yes, I think it's definitely complicated having to sort out whether one's flu or whether one's got COVID, or God forbid one has both, which will be challenging. But I'm very much hoping we have a lesser flu season this year because of COVID.
Great points. Dr. Chow?
I share Tracy's, Dr. Davidoff's sentiment too. I'm actually somewhat hopeful that we will see improved vaccination rates. We will continue to practice good social distancing, that we will continue to practice good infection control in our urgent care centers. I'm also hopeful that we will actually have better testing options and better understanding of how the tests play a role in the diagnosis of both flu and COVID and any other respiratory illnesses.
Excellent. Dr. Burris?
Yeah, I just have one very, I think, pragmatic point, and that is during this time of COVID-19, we should encourage patients to treat their allergies effectively. A lot of people just sniff and blow and get on with it, but the optics now are such that the coworker next to them, they're worried that might be COVID. So I've been encouraging the people that I'm speaking with to please go out of their way to treat their allergies a bit more effectively, perhaps with adding Flonase over the counter, for example. But everybody in Oklahoma in the spring has allergies, it seems. So just treat it more effectively so we don't have to be confused by that.
I can tell you that's definitely here in Ohio as well. My allergies are killing me right now. Trying not to look like I've got a runny nose and COVID here. Okay, well, thanks very much for the answers to that. Another question, several questions that revolve around back to work. You talked about the two methods to get back to work. One was a time frame method with lack of symptoms. The other one was a testing method. I've also seen when we were testing everybody and retesting, I've seen 4 or 5 patients who had 5 tests and they were still positive, but they were completely well and they were angry because their work wouldn't let them go back to work. How do we deal with employers who have unrealistic expectations for return to work or what needs to be done, or don't even understand what these tests are good for? They want this antibody test, they want this other test. Why don't we start with John? We'll go backwards this time. Dr. Burris?
Yes. So interestingly, that came up early in Boston. There was a biotech that brought all their executives from all over the world, and it was a super spread event. They had all these positives, and they quarantined all these individuals, these top C-suite people, and some of them, the public health would not let them go for weeks. They had persisting positive PCRs, and a colleague of mine finally had to say, enough. Let's free these people, because the test base, and that's my somewhat of a experienced bias against test based, because you'll see these persistent positives. They're fragments of PCR, perhaps, and it can be a real problem. So if you have a company that's going to go that way, then ahead of time say, look, if they're persistently positive, then let's get an antibody test and put that in the mix, and you're just going to have to give up. You can't hold these people in quarantine because there's no evidence that they're infectious. So that is a problem, a known problem, and it will rear its head. So.
Makes sense. Dr. Chow, thoughts on that?
Yeah, I think the one of the issues with nucleic acid testing is it's too sensitive. I mean, if it picks up the RNA, it's going to come back positive. And just like in flu, where you can see positive flu tests that go beyond a zone of contagion or symptom relief, the problem with the tests are, if someone's persistent positive, they may not be infectious, and they most likely aren't infectious. And so I don't have a better solution for that. Perhaps the antibody test may play a role, but at the same time, we don't really know when antibodies are produced, when they're produced, and what timeline they follow.
I think maybe only the future will tell. Dr. Davidoff, thoughts?
I don't really have an answer for any of that. I mean, most of the workers that we see in my job are first responders and healthcare workers, and absolutely not allowed to go back without a negative test. Everybody else that I've seen, hotel industry and that sort of thing, most of them are amenable to the time-based strategy as opposed to the test-based strategy, but which is helpful. To allow people to go back to work a little bit sooner. My thought is, if you're not sick and spewing secretions all over the place, you're probably, even if the test is positive, you're probably not contagious. But, I don't know how you would tell an employer who likes to see things black and white, that, okay, they can go back to work even though they have a positive test. And that's the rub. I think we just don't have a good way right now, and that I see that evolving in the future.
Thanks. Dr. Vogel? Are you on mute?
Yes, I was on mute. Thank you for that. Yeah, just a couple of points on that. I think we at our organization and me personally as a provider have been more inclined towards time-based / symptom-based, decision making when it comes to return to work. And the reason being because of all the reasons that have been stated. We just don't know enough about tests when they turn negative, and what that means if they turn negative. So we're pretty much going with the CDC guidelines for symptoms-based, or time-based, decision making when it comes to return to work. And my second point is that it's extremely important that we also do call up and talk to the employers who are sending these patients, because I've done that quite a few times over the last 2 weeks already, where I've called the employer and said, hey, we're happy to see your patients. We will absolutely be happy to and thrilled to assess them and make a clinical decision whether they can return to work based on our protocol, which is based on CDC guidelines and is symptom based, and then trying to help them understand that you really don't need to test every single employee of yours, which is usually their first go-to, that, oh my God, we need a test on everyone just because, Susan sneezed, in some corner of their office. So I think it's a lot to do with communication. I mean, we are healthcare providers and we are confused about this. Think about the general employer who's trying to just keep his, business afloat. They're even more confused and panicked. So I think there's a lot of panic around this question, and the more communication we do with them, the better.
All right, Dr. Toscano, we need your magic bullet. Your last but not least.
Okay, well, I don't know if I have the magic bullet, but we've been fortunate. Based on ID consultants and the county health department recommendations, we've been using exclusively a non-test based, time-based strategy for returning people to work, and the employers have been accepting of that. I think and we haven't had any news of any secondary infections. I think it's really been aided by the very aggressive shelter in place in our county here, where there's only essential people at work, and then they're all wearing masks. And I mean, a lot of those folks are wearing PPE, taking care of the whatever work they have to do, first responders, et cetera. And I think that's the additional safeguard that makes that work for us.
Great. Okay. I guess there is no magic bullet, but we knew that kind of coming into it. So back to the medications and treatment. Dr. Dadoff gave us some great answers and some great information on what we should or shouldn't be doing, which is kind of shouldn't be. Does anyone else have any comments on medications, what they're seeing or concerns they have that they wanted to express? Dr. Toscano?
Yeah, I think in urgent care, just to avoid prescribing anything, and in the ED, as well. As patients get admitted, there's still research ongoing. Remdesivir looks like it could work. That ACT trial, they released some early data. 5 days may be sufficient in hospitalized patients, so that basically doubles the supply of that if we start to hit a surge again. The IL-6 inhibitors like Actemra in patients who are really sick, cytokine storm ICU patients, actually at our hospital in the ICU have had some success with that. But those are all, out of the realm of urgent care. I think whether there's going to be some pill that works for this, maybe some type of antiviral that could be taken in outpatients, we got to hope for that, but there's nothing on the horizon that I know of.
Dr. Bogle, any thoughts?
I think supportive care is important. We should not forget that just because they don't have, we don't have any medicine for the actual virus or the disease, we still need to continue with providing supportive measures to the patients, in terms of cough medications or whatever, based on their symptomatology. I think that's one piece of it. And the other is making sure that we are still practicing good evidence-based medicine when it comes to treating pneumonia or pneumonia-like findings that we have been seeing in COVID patients, those bilateral infiltrates and whatnot. We need to make sure that we are doing the right kind of antibiotic prescribing in those situations. I believe the CDC has some good information about those, antibiotics, doxy plus amoxiclav and all that stuff based on that information. But we really do need to keep in mind supportive care, and then pneumonia is something that we need to be very careful about. And then, we still don't need, I want to talk about the tunnel vision a little bit as well. Don't forget PEs, that's an important one. So kind of expanding the diagnosis a little bit as well. Thank you.
Thanks. Dr. Davidoff?
I'm sorry, what was I supposed to comment on?
Just essentially, with anything else extra that you want to add to the don't medicate, or what should you do with patients if they're presenting in the urgent care space?
Oh, okay. I thought I was immune to this question because I had given this part of the talk.
I should have been, but I put you on the hot seat anyway.
No, yeah. I mean, my big thing, it's regional, but I really don't like the idea of people giving antibiotics willy-nilly so that they don't have to examine a patient or see the patient in person. Just all sore throats are not strep, so don't knee-jerk the amoxicillin for the sore throats and that sort of thing. Take the time to talk to patients, and the education piece as well. Education goes a long way in not having to write a prescription for someone, and keeping them happy.
Excellent thoughts. Dr. Chow?
My only comment is that it seems like for a while there, over the past 2 months, every day or every week, there was a new flavor of the month treatment in the media. And our role in urgent care is to talk to patients and give them reasons why hydroxychloroquine, azithromycin, I've heard ivermectin, then it was famotidine, why these medications are not appropriate to be taken either for prophylaxis or even for mild or moderate symptoms. The reality that we're seeing is that most of our COVID positive patients do have mild and moderate disease, and it is reassurance to the patient that supportive care is necessary and to monitor the symptoms. From an urgent care perspective, there is no medication that we can really treat, so it's all about education and supportive care.
Excellent thoughts. Dr. Burris?
Yes, I would echo Chris and Tracy's comments, and I would share with you, I took care of telehealth-wise a 65-year-old utility worker in Philadelphia whose mother was 95, living in the home, one bathroom. The wife comes home with COVID, having worked in a mental health hospital. That man took care of the household, cleaned, fed, kept his mother alive, and his wife got better and went back to work. Yeah, I felt great sense of gratification talking with this gentleman, helping educate him about isolation, etc. But I think for we as healthcare providers to deliver that type of education is life-saving.
Excellent thoughts once again. So we're about 20 minutes past when we thought we were going to end this. We've had some great conversations. There's still a lot of questions, although I see Dr. Toscano has been busy answering everybody's questions with excellence there. So we appreciate that. I'm going to give everybody one last chance to give a final thought, and then we'll go ahead and close this up. As I said, this will be recorded, and we will also try to get back to everyone with some of the questions that were missed. Make sure that you know that there's also a COVID listserv that UCA and CUCM is running. That's a great place for good information. Check that out. And we look forward to seeing everybody else in the future. Dr. Toscano, last thoughts?
Sorry, just caught me typing. I think we covered things well. To me, the thing that we need, the kind of the missing piece, apart from treatment, is how to understand how to use the test results. I think there's a lot of confusion, and as John had mentioned, maybe even some incorrect decisions being made. You can envision incorrect decisions being made on test results that may be true. I mean, the test result may be true, but we don't know the implication of it. And so I think we have to understand a lot more about testing, what the results mean, what the implications are as this thing unfolds further, particularly if we're going to have to deal with it in the future. So that's what I'm looking forward to.
Okay, I'm going to mess things up. John, can you give us Dr. Burris, could you give us a final thought?
Yes. The initial PCR, 1 in 5 is going to be a false negative. Go with your clinical gut. If 3 other people in the home have COVID symptoms, that person is presumed positive and treated accordingly. Don't let that person say, yay, my test is negative, and they go home and hug their kids and they hug their spouse and they go to work and they expose, numerous other people. Say to them, look, there's a good chance this could be a false negative. And then have a follow-up conversation. Retest the person in a few days if you need to, but don't let that person, feel like they're done. Okay, thanks.
Excellent. Dr. Chow, we'll ask you next.
Well, I think if you asked me privately what I thought of COVID and SARS-CoV-2 back in February, I was very frightened and very concerned. But I think that as we've gotten to know more about the characteristics of this virus, the symptoms and the syndrome, I actually feel better about it now. My advice is, this is frightening because it's unknown, but at the same token, the principles of good medicine, the principles of infectious disease, and the principles of infection prevention do not change whether or not this is influenza, whether it's Ebola, or whether it's SARS-CoV-2 or COVID. So continue to follow the evidence, continue to follow what our training has taught us about infection prevention, and just continue to monitor for new developments. That's all I have to say. And that's, now I'm going into it with a little bit more hope that by the fall, we will actually have better answers and we'll have better control and command of this illness.
Great thoughts. Thank you. Dr. Davidoff?
Something that I haven't mentioned, but something that's important when we're talking about the testing and the medications is please don't give in to the misinformation train. It's out there, you know, we're being bombarded with information from this from every angle, every direction. I mean, I have probably 30 in my inbox every morning when I wake up, you know, on Facebook, you know, cousin Bruce has an opinion, you know, we get information from so many different angles. You know, the only stuff that's really important, that's really true, is stuff that comes from a very reliable source. You know, the CDC, JAMA, NIH, World Health Organization, you know, things that, you know, not MSN, not Fox News, you know, so please, you know, before you make any decisions about what you're going to do as far as testing or medications or sending people back to work, you know, make sure you get it from a good source like us. No, you know, look at your sources periodically and make an informed decision and an informed choice. You know, don't rely on what other people are telling you unless they're a really good source.
Great advice. Unfortunately, I've left Dr. Bogle the last, so everyone's taken his great ideas, but we'll give him an opportunity to chime in as well.
Sure. Thanks, Sean. Don't let your guard down. I guess that's the one message that we should be telling our patients repeatedly, and also our staff and also ourselves, that we really are not, you know, out of it yet. We have a lot of uncertainty going forward as well. Don't let your guard down. We need to follow all those basic things that everyone has already talked about, so I don't want to repeat them, but it's important to understand the seriousness of this condition, of this issue, of this virus. And like I said earlier, we need to respect this illness, and we need to continue respecting this illness. That's what I would say.
Great. Thank you very much to our panel. It's been an excellent conversation we've had here. I know that we didn't answer all the questions, but I think all the questions aren't answered. I'd also like to thank all of the people who've participated in the town hall meeting here. I know that it's not as easy to be able to ask questions with all that's going on and being connected in this manner over the web, but that's kind of become our life as it is now. I want to remind everyone about a few things, that there is a COVID listserv that is all about COVID and about all kinds of questions. Lots of great information going on there. The UCA convention, although canceled in its usual format, is on demand, and it has started just Monday, just a couple days ago. Be part of that. And this recording will be available for all those who signed up, whether you joined us or not. And we're going to try to help you with some of those questions. Thanks, everyone, and have a great day.
Hi, everybody. This is Carla. I just have I need to make a quick plug for our sponsor, Quidel. Quidel has introduced the first antigen-based SARS-CoV-2 assay on the Sophia platform. Having this assay available on-site and at most appropriate point of care allows urgent carers the ability to test more people quicker and more often. With nearly 1 million tests delivered in less than a month, we can help you identify positives immediately, then trace, isolate, and stop the spread. Please go to quidel.com/support for more information. And thank you all to the panelists and everybody who attended. This will end today's town hall meeting. Thank you.
Thanks, everybody. Stay safe.
Thank you.
Take care. Bye.
Bye.